Good morning. My name's James Danger, and this video is on a fairly sensitive topic of transrectal oocyte retrieval. The paper was published just recently in Obstetrics and Gynecology from a group of Egyptian authors looking at transrectal versus transvaginal oocyte retrieval in patients requesting egg freezing for fertility preservation. So we all know that transvaginal egg retrieval is a necessary procedure, but it requires considerable sensitivity. Nearly all women accept this procedure, but they do it reluctantly. And I'm very conscious that I'm really quite the most inappropriate person to be talking about this procedure. However, there are occasional cases where it is not possible or unacceptable for cultural, personal, or private reasons. There are other options available, but these are often more invasive and problematic, particularly in unskilled hands. These include transabdominal and transrectal procedures. With more women attending for reasons other than infertility, clinics need to have policies in place and some degree of experience to allow women alternative options for oocyte retrieval. Of course, the historical laparoscopic procedures that are performed in the very early days of IVF and for gift and prostate in the 1980s are other options but carry their own risk for multiple pregnancies. But these are not for people trying to fall pregnant. These are for people wishing to have their eggs frozen. And often they come in, they are single women, and some of them have had no sexual experience at all. So the conclusion from this study, so you know where I'm going, but I do have some comments at the end which may be important to you. Transvaginal oocyte collection is the standard and easiest method for oocyte retrieval. However, for patients with an intact hymen, particularly in regions with cultural and religious considerations, transrectal oocyte collection is also regarded as a safe and a simple alternative, and this paper provides some information to demonstrate that it is safe. The method of oocyte collection is a crucial factor in the success of oocyte freezing cycle. It's widely recognized that the transvaginal approach is the simplest and the most commonly employed technique. Laparoscopic oocyte aspiration is an invasive procedure compared to the transvaginal method. It poses a considerable risk of vascular and internal trauma, and I've seen this in the past, back in the early 1980s, and that's how it was all performed. Increased bleeding, a challenging approach, internal visualization of the follicle, and the necessity for a proficient laparoscopic surgeon, extended surgery duration, anesthesia complications, and an extended hospital stay. What women went through in the 1980s for IVF is just almost unimaginable in these days. The presence of an intact hymen may interfere with the required transvaginal ultrasound-guided oocyte aspiration, and hence the acceptability of oocyte collection for freezing, especially in some cultures and areas for like example, the Middle East. Neurosurgeons have long practiced transrectal prostatic biopsy with minimal or no reported complications. So why not perform oocyte retrieval in a way that avoids hymen disruption, allowing patients in these areas the opportunity to freeze their oocytes for fertility preservation? The population considered in this study included all women with an intact hymen from the Middle East and Far East who cannot do transvaginal ultrasounds and wish to keep their intact hymen due to cultural and religious concern. There are millions of them. This study supports fertility preservation in women without breaching their cultural and religious concepts, and I think this is really important. If the treatment is for embryo transfer, clinics need to consider the procedure appropriate for both collection and transfer and inform the client before starting treatment, since the issue of egg retrieval may also apply for embryo transfer, but maybe at a later date. But there are options. In the very early days, we used to put embryos back in the fallopian tube in a procedure called PROST, and that had about the same outcome as normal embryo transfer. So in this study, looked at about 125, 106 women seeking oocyte cryopreservation who were allocated either to transrectal or transvaginal oocyte recovery. And basically the data is really interesting because there's no difference. Here we go. The age was much the same, BMI, they were all very similar. But what was interesting was that even though the transrectal had slightly lower AMH, that is, they had slightly more ovarian insufficiency, they still ultimately would produce the same number of eggs. But interesting, the anesthetic time was a little bit less. I'm not quite sure why, but it was significant in the hands of the surgeons. And the surgery time was also considerably less. So for some reason, maybe the Purge wanted to get the procedure over and done with, I don't know. But if you look at all the other data, The patients are basically the same, but the egg numbers of collected and mature eggs were both identical. In other words, it's the same success aspirating the follicles with either method. And this is a terrible graph. It was actually fairly poor in the publication, and I can't make it better by showing on the screen. But essentially, that look, there's the number of follicles and the age, BMI, AMH, anesthetic time, surgery time, and peak estradiol, they are all exactly the same. Although the insemination theoretically is a little bit better. And I love this graph. This is the intraoperative complication, the post-operative complication. This is one you'll be concerned about with some form of post-hospital infection, right? And that's what you'll be really concerned about. And the answer is 0. So they're obviously very skilled surgeons. So I'm going to use the surgeons' comments from their discussion here rather than make my own comments, but I do have a few comments right at the very end. So the author's summary was, in our study, we compared the standard vaginal route with new transrectal route. We found no significant difference between the two groups, as transrectal show comparable reproductive outcomes to transvaginal. We evaluated the complications that might occur from the ovum pickup, and no intraoperative or postoperative complications were observed in either group, supporting the safety of transrectal or transvaginal as an oocyte retrieval. Beyond this setting, transrectal may also have wider implications for patients with anatomical surgical barriers to transvaginal access. This includes transgender men, especially those having undergone or are planning gender-affirming procedures where transvaginal access is not possible. Another method for oocyte retrieval is transabdominal fluid aspiration, which will be considered in patients requiring an intact hymen or in cases where ovarian access is limited due to anatomical factors. However, it's a more sophisticated procedure due to limited follicular view, high body mass problems, presence of other organs, difficulty in seeing the end of the needle, and the possibility of organ and vessel injury. In this study, the authors compared the standard vaginal route with the new transrectal route and found no difference between the two groups. We evaluated the complications that occur from the ovum pickup, and there were no intraoperative or postoperative complications in either group. Although the transvaginal oocyte collection is a standard method for oocyte retrieval and is confirmed to be the safest and easiest way for patients with an intact hymen, particularly in regions with cultural and religious considerations, transrectal oocyte collection is considered another safe and simple route. Given the limited available evidence on transrectal procedures, the present results could add to the growing but still emerging literature on this technique. And my final comment is that I've come across this issue several times in my IVF career. I think I've been the embryologist for about 5 cases where we had to use either abdominal or transrectal, and I have to say it's quite a challenging thing to do that. I think, particularly for people who are not clinicians, but in all cases, it was seemed to have been accommodated and without any problems. Transrectal and transabdominal alternatives are available with less experienced medical staff in these procedures. This paper does show that a transrectal approach has similar outcomes to transvaginal, but the reason for doing this video is to highlight this paper as a reference for you, for anyone planning to do this in the future, because these cases come out of nowhere very quickly. And with oocyte freezing, we're going to have more and more cases. But we've had a few cases over the years of people who have vaginismus, previous SALT cases, which makes it all very difficult to do transvaginal ultrasound. And clinics, particularly those busy, need to have procedures in place and counselling skills up to date to handle these cases when they appear out of nowhere. I'd like to finish there. My name's James Danger, I'm an embryologist with almost 50 years experience. I'm not a medical person, and this information is not medical advice, but hopefully it may help you know what questions to ask about your treatment with your doctor and maybe help in understanding the advice you receive. If you like what I'm doing, press subscribe, press like, and leave a comment and tell other people about this program. I won't talk about my own program here. I'd like to stop at this point in time. I recognise IVF is a difficult journey for many people, and I hope this article does help you in some way. At this point in time, I'd like to say thank you for your attention and ciao.